Hello, my name is Dr. Yolanda Pickett. I'm a geriatric psychiatrist who consults for a large home care agency in the Bronx. And today I'd like to talk to you about the use of selective serotonin reuptake inhibitors, or as they're more commonly known as SSRIs, in the treatment of depression. So first let's talk a little bit about serotonin, which is a hormone that's found in various parts of the body, not just the brain. As you can see here, serotonin can be found in the digestive tract, the central nervous system, the pineal gland, which is responsible for our circadian rhythms, and blood platelet cells, which are responsible for clotting. In the brain, serotonin acts as a neurotransmitter, and it transmits electrical impulses from one neuron to the next. This is the action of serotonin that has the greatest effect on mood. So there are many ways that serotonin regulates the body and brain functioning. It can affect your mood, sleep, appetite, sexual desire, and cognition. And changes in the level of serotonin can interfere with these functions and can lead to symptoms that we see in depression. The decrease in serotonin, as I said earlier, can cause depressive symptoms. And the levels of serotonin can be reduced in a number of ways. There can be a low production of serotonin in brain cells, a decrease in the number of receptor sites that bind serotonin on brain cells. There can be an inability to bind properly to these receptor sites, and there can also be a reduction in the storage of a precursor chemical, which is called tryptophan. Tryptophan is used to make serotonin in brain cells the same way as it's used to make melatonin, which regulates our sleep-wake cycles. As you already know, one of the most widely used treatments for serotonin deficiency are the SSRI antidepressants. So let's talk a little bit about how SSRIs work. So they bind to postsynaptic neurons and block the resorption of serotonin in the neuron synaptic region. This causes an increase of serotonin levels for that neuron. This allows for there to be more available serotonin binding in the postsynaptic cell receptor sites. To make this point a little bit clearer, let's look at the illustration on the next slide. So here you can appreciate that in the highlighted region, serotonin is produced in the cell and carried by vesicles to the nerve ending of the presynaptic cell. And then it's released into the synaptic region, where it binds to receptor sites in the postsynaptic nerve ending. And this allows for the electrical impulses to be carried from the presynaptic nerve to the postsynaptic nerve. And this is what regulates our bodily functions. So if there's a decrease of serotonin in the synaptic space, there's not going to be enough to bind to the receptor sites in order to effectively carry these, to effectively transmit these impulses from one nerve to the next. And after the serotonin is done binding to the receptor sites, it's usually reabsorbed back into the presynaptic nerve ending. Well, if the SSRIs are on board, as you see here in the highlighted region, they can block the resorption of serotonin back into the presynaptic nerve endings. And this causes serotonin to stay in the synaptic region longer, which allows for more time to bind to the receptor sites and more time for the neural impulses to be transmitted and for normal bodily functions to occur. So staying in the synaptic region longer allows serotonin to regulate the functions of the body more effectively, which can reduce the depressive symptoms. So there are different types of SSRIs that are on the market today. They've been around since 1987 with the introduction of Prozac, or fluoxetine as it's known by its generic name. There are also others, Paxil, Zoloft, Celexa, and Lexapro, that are all now available in their generic forms. I just like to note that in older adults, we need to be a little more careful about prescribing antidepressants. We usually start with the very low doses for older adults, and we go very slow in increasing the dose until we get to a therapeutic dose. Um, we use Prozac and Paxil with caution in older adults for a few reasons. First, these two are metabolized in the liver in such a way that they can cause drug-drug interactions with many of the other drugs that older people take. Secondly, Paxil can cause some slowing of a person's cognitive functioning, which happens more in older adults, and can also cause sedation, which can cause fall risk for older adults. So we try to use this very sparingly in older adults. Also, Celexa has some cardiac side effects that can be related to very severe um, side effects such as palpitations, fainting, and even sudden death. And there's been a limit on the dose range for Celexa in older adults that we try not to use any more than 20 milligrams because these effects are seen at ranges above 20. I'd also like to call your attention to another SSRI, Luvox, which I'll mention here because it is an SSRI to be complete, but it's not used for the treatment of depression. It's used for the treatment of OCD. So we rarely see this used for depression. So there are many side effects that you see with SSRIs. These are some of the most common. I like to bring your attention to a few that also may be symptoms of depression, such as headache, reduced libido, insomnia. Patients may complain about these side effects after the initiation of an SSRI, but it's important to ask the patient when the symptom actually started. It can be a symptom of the depression that they're just being aware of, that they may blame on the medication, but it's actually more a symptom of depression. So it's very important to ask, when did the symptoms start? If a patient is having difficulty tolerating an SSRI because of the side effects involved, and they don't go away after about a week, it's very important to alert the prescribing physician so that the medication can either be reduced, adjusted in some way, or switched to a different medication. And the first line of activity would be to maybe switch to a different SSRI because they don't all have the same side effects and would all affect the patient in the same way. So just to end, I just wanted to alert you to some of the contraindications or interactions that can occur with SSRIs. These antidepressants can increase the blood concentration of medications like warfarin, digoxin. These medications can be monitored in some aspects by lab tests, but some can't. So it's important to know that this interaction can occur and to just be mindful of it, and to maybe reduce an SSRI dose if you see that it's interfering with another medication. Also, patients with chronic pain, arthritis, may use ibuprofen, naproxen on a more frequent basis, which can reduce the levels of SSRIs, so the SSRI might need to be increased in these cases. And lastly, certain agents like alcohol, diuretics, Ambien, and other agents can increase SSRI levels, which in these cases we need to be aware because an increase of serotonin in the body can cause some mental status changes, hyperthermia, hypertension, different side effects that we need to be aware of, because if that's the case, these medications need to be reduced. And levels of serotonin, very high levels of serotonin in the body, can produce something called a serotonin syndrome, which may lead to death in some patients. So it's very important to monitor patients that have been put on these medications that are also using agents like diuretics and alcohol on a regular basis. This ends our discussion on SSRIs. Thank you for participating. I hope you enjoyed my presentation, and I hope you will also visit our web library for our other mini lecture series topics. Thank you.